Hello everyone, this is Dr. Sangeeta Chaudhary once again and I welcome everybody to my class. In my today's class, I am going to discuss a very important topic, that is hypothyroidism. We all have heard about hypothyroidism and many of us we do suffer from hypothyroidism. So let's discuss about the disease. As the name suggests, hypothyroidism, that means lack of thyroid hormones. So what are the causes of hypothyroidism? More than 90% of the cases, hypothyroidism is due to primary disorder of the thyroid gland, that is primary hypothyroidism. Primary hypothyroidism is seen more in females and it is most of the time due to autoimmune condition. There is something known as chronic lymphocytic thyroiditis, or also known as Hashimoto's disease. Hashimoto's disease is the most common cause of hypothyroidism in developed nation. It is also seen most of the time in females. Iatrogenic hypothyroidism can also occur as a result of thyroidectomy. Okay, there are many situations where the patient has to undergo removal of thyroid gland, which ultimately results in permanent hypothyroidism. Or radioactive iodine treatment can also result in iatrogenic hypothyroidism. There are hypothyroidism which are due to transient causes like postpartum thyroiditis and subacute thyroiditis. These patients, they do improve in the later period. Infiltrative disorders of thyroid gland, for example, sarcoidosis, hemochromatosis, these are the infiltrative disorder where there will be hypothyroidism. Irradiation of the neck, which involves the thyroid gland, which may result in hypothyroidism in future. There are certain drugs which can also result in hypothyroidism. For example, iodine-containing drugs like lithium, interferon alpha, interferon beta, thalidomide, sunitinib, and amiodarone. Okay, these are the drugs which which may cause primary hypothyroidism. May cause hypothyroidism. Now, congenital hypothyroidism is also there. It is due to agenesis of the thyroid gland or sometimes dysharmonogenesis. Now, disorders of pituitary and hypothalamus can also result in hypothyroidism. This is usually the main cause of secondary hypothyroidism, where there is abnormality in the pituitary or in the hypothalamus, which results in hypothyroidism. So these are the causes of hypothyroidism. Now coming to the clinical features. What will be the symptoms of the patient when they come with hypothyroidism? Most of the time the symptoms are very non-specific and these are of gradual onset. Patient will complain of cold intolerance, poor memory, increased sleepiness. They may complain of constipation, menorrhagia, myalgias, and hoarseness of voice. So these usually remains the patient's complaints. Of course, these are not very specific. These are kind of non-specific complaints, but we need to have a good clinical suspicion to think of hypothyroidism. On examination, they tend to have bradycardia, slow relaxation of tendon reflexes, which is also known as hung up reflexes. Right? Slow relaxation of tendon reflexes, deep tendon reflexes. There may be mild weight gain. We need to remember that hypothyroidism causes mild weight gain, not too much of weight gain. There will be dry skin on examination. There will be facial or periorbital edema. Non-peating pedal edema can also be there. So hypothyroidism is one of the cause of non-peating edema. And there may be myxedema in severe cases of hypothyroidism. I'll discuss myxedema separately in my myxedema coma actually. Okay, so I'll discuss about myxedema coma in a separate class, right? Diagnostic testing. Okay, how do you diagnose a case of hypothyroidism? Of course, plasma TSH is the best initial test for diagnosis of hypothyroidism, because in mild cases of hypothyroidism also plasma TSH will rise. Okay, and if plasma TSH is normal, we can almost rule out hypothyroidism. Antibodies to thyroid peroxidase is very important. Antibodies to thyroglobulin is very important, right? We need to do this test. We can do an ultrasonography of neck or ultrasonography of thyroid gland. Radioactive iodine imaging can be done. Other ancillary or supportive tests like ECG can be done, where there will be bradycardia. Lipid profile we can do, where there will be increased level of cholesterol and triglycerides. We can do a sodium level. We may find hyponatremia. And we can do a creatine kinase where there will be increased level of creatine kinase. If we are suspecting secondary hypothyroidism, in secondary hypothyroidism, TSH will be normal and there will be reduction in free T4, right? So other pituitary hormone levels we need to look for. We need to look for if there is a deficit of other pituitary hormones, because secondary hypothyroidism means there is disorder in the pituitary or hypothalamus, and of course we need to do brain imaging tests to rule out mass lesion in the pituitary and hypothalamus. So these are the investigations which we do in cases of suspected secondary hypothyroidism. Lastly, coming to the most important part, that is treatment. So how do you treat such patients? Thyroxine remains the drug of choice, so we need to supplement thyroxine. We need to give thyroxine replacement. What is the dose of thyroxine replacement? The average dose of thyroxine replacement is 1.6 to 2.3 microgram per kg per orally daily. We need to stress that it is a lifelong treatment. We need to counsel the patient regarding this. And thyroxine supplement should always be taken 30 minutes before breakfast, because there are many foods which can hamper the absorption of thyroxine hormone from the gut. So it should be taken at empty stomach at least 30 minutes before breakfast. And we also need to advise the patient not to take any calcium containing medicine or iron preparation or PPI or antacid syrups, okay, concomitantly with thyroxine replacement, because they also will alter or hamper the absorption of thyroid hormone. Initiation of thyroxine. How do we initiate? At what dose we initiate? For young middle-aged people with hypothyroidism, we usually initiate at a dose of 1.6 microgram per kg per day. For healthy elderly, the starting dose is little low. We usually start with 50 microgram per day. And for people with cardiac disease, we start at a more lower dose, that is 25 microgram per day, and we observe the patient for any, deterioration of cardiac disease. How do you do follow-up? Very important. As I said, thyroxine replacement is for life. So we need to really follow up the patient and adjust the doses of thyroxine replacement. After initiation of thyroxine, we need to advise the patient to come after 6 to 8 weeks. If TSH is still high, means TSH is still elevated, we will adjust the dose at an increment of 12 to 25 microgram of thyroxine increments at intervals of 6 to 8 weeks until TSH becomes normal. And once TSH is normal, we can do annual follow-up. Annual measurement of TSH can be done, right? But in cases of secondary hypothyroidism, we cannot depend on TSH for monitoring. As we say, TSH is usually normal in such cases. So we need to monitor such patients with free T4. Okay, we need to keep free T4 within the range. Okay, at least at the upper limit of the reference range, and dose adjustment to be done every 6 to 8 weeks. And once everything has settled, free T4 is normal, thereafter we can do annual measurement of free T4. So this is how we should monitor for secondary hypothyroidism. For primary hypothyroidism, the monitoring should be done with TSH, and for secondary hypothyroidism, monitoring should be done with free T4. So that is all about hypothyroidism which I wanted to discuss. In my upcoming classes, I will talk about myxedema coma, and I will talk about thyroid replacement in specific situations or in specific group of population with hypothyroidism. Thank you so much for attending the class. I hope this class will be really helpful for the students as well as the practicing physicians. Thank you.